It is 8:30 on a Monday night in Stampsville. A 55-year-old man walks into your emergency department. He is clutching his chest, he is gray, sweating profusely, and he tells you the pain started 40 minutes ago while he was watching television. It is crushing, central, radiating to his left arm. He feels sick.
This is the presentation every rural generalist dreads. You know what it probably is, but in Stampsville you have no cath lab, no cardiologist, no CT scanner, and your retrieval team is 90 minutes away. Every decision you make in the next 10 minutes changes this man's chance of survival.
Good morning. It is Thursday the 14th of August. This is STAMPS Daily. 91 days until your CGT StAMPS examination. Phase 1, Foundation. Today we tackle one of the highest yield presentations in rural practice, acute chest pain in a center without percutaneous coronary intervention.
A roadmap. Deep Dive A is the structured approach to chest pain in the rural ED, ECG interpretation, the immediate drug bundle, and the thrombolysis decision. That is where most candidates fall down. They know the theory but cannot articulate the door-to-needle logic under pressure. Deep Dive B covers the dangerous mimics, aortic dissection and pulmonary embolism, both diagnosed without CT. Then rural integration, examiner lens, and active recall.
Let us set the scenario properly. 55-year-old man, known hypertension, on perindopril 5 mg daily. Smoker, 30-pack years. Father had a myocardial infarction at 52. He describes the pain as 10 out of 10, central, crushing, radiating to the left arm and jaw. It started at rest. He has never had pain like this before. He is diaphoretic, pale, and nauseated.
Before you reach for the troponin, walk me through your opening 30 seconds. How do you start this in the exam?
My opening statement. This patient has features highly suggestive of an acute coronary syndrome. My immediate priorities are to confirm the diagnosis with an ECG within 10 minutes of arrival, begin initial medical therapy, and determine whether he requires reperfusion either by primary PCI at a regional center or fibrinolysis locally. I will simultaneously assess for and exclude life-threatening mimics, specifically aortic dissection and pulmonary embolism.
Good. You signposted, you named the diagnosis, the immediate action, the decision point, and the mimics. That is the structure. Now tell me what happens in the first 5 minutes at the bedside.
The patient is transferred to a resuscitation bay. The nurse attaches monitoring, cardiac monitor, oxygen saturation, blood pressure, and a 12-lead ECG. I am asking the nurse to gain intravenous access, take bloods including a point-of-care troponin and a venous blood gas while I interpret the ECG.
Stop. You mentioned bloods before you mentioned treatment. What drug are you giving right now while the ECG is being done?
Aspirin, 300 mg orally, chewed or dissolved. This is recommended by the Heart Foundation and Cardiac Society of Australia and New Zealand guidelines from 2025 unless contraindicated. I am checking for true aspirin allergy first, and if there are no contraindications to nitrates, I am giving glyceryl trinitrate, 1 spray or 1 tablet sublingually, and repeating every 5 minutes up to 3 doses if the pain continues.
Contraindications to GTN. Name them.
Systolic blood pressure below 90 millimeters of mercury, recent use of a phosphodiesterase inhibitor, sildenafil or tadalafil, within the last 24 to 48 hours, right ventricular infarction, which I would suspect in an inferior STEMI, and suspected aortic dissection, where reducing afterload could worsen the dissection. If any of these are present, I withhold GTN and move to opioid analgesia.
And the opioid, what exactly are you giving?
The guidelines say intravenous fentanyl or morphine boluses for ongoing pain not responsive to nitrates. Morphine, 2.5 to 5 milligrams intravenously, titrated, or fentanyl, 25 to 50 micrograms intravenously. I would start with a small dose and reassess. The ANZ Core guideline from 2024 notes that opioids may delay antiplatelet absorption, so I use nitrates first and reserve opioids for significant ongoing pain.
Oxygen, are you giving it?
Only if he is hypoxaemic. The ANZ Core guideline and the Heart Foundation guidelines are clear. Routine supplemental oxygen in normoxic patients with suspected ACS does not improve outcomes and may cause harm. I target oxygen saturation above 90%. If his saturation is 95% on room air, I do not give oxygen. If he drops below 90, I start 2 liters via nasal prongs and titrate.
Important point. A lot of candidates reflexively put every chest pain patient on 15 liters of oxygen. That is no longer standard. Now, the ECG. Walk me through what you are looking for.
I am looking for ST elevation, ST depression, T-wave inversion, new left bundle branch block, and hyperacute T-waves. The ECG must be done within 10 minutes of arrival. That is the Heart Foundation standard. If I see ST elevation in 2 contiguous leads meeting the criteria, that is STEMI, 1 mm in limb leads, 2 mm in chest leads in men, or 1.5 mm in women in leads V2 to V3.
What if the first ECG is normal? Does that exclude ACS?
No, up to 20% of acute myocardial infarctions present with a normal or non-diagnostic initial ECG. I would repeat the ECG at 15-minute intervals if the pain is ongoing, and I would look for the subtle patterns. Posterior MI showing ST depression in V1 to V3 with tall R waves, right ventricular involvement in inferior STEMI, which I confirm with a right-sided lead V4, de Winter T waves, which are upsloping ST depression with tall symmetric T waves in the anterior leads. These are STEMIs that do not show classic ST elevation but require immediate reperfusion.
That is exactly the level of detail the examiner wants. You did not just say repeat the ECG. You named the specific patterns that are easy to miss. Now, let us say the ECG shows ST elevation in leads 2, 3, and a VF. Inferior STEMI. What is your next step?
This is a STEMI. Reperfusion is the priority. The Heart Foundation guideline says emergency reperfusion within 12 hours of symptom onset, either primary PCI or fibrinolytic therapy. The decision depends on timing and access to PCI.
In Stampsville, no PCI available. What is the threshold?
The guideline is explicit. Primary PCI is preferred if it can be delivered within 120 minutes of first medical contact. If it cannot, fibrinolysis should be delivered within 30 minutes of first medical contact. contact. In StAMPSville, the regional PCI center is 295 kilometers away with a 90-minute flight. There is no way PCI will happen within 120 minutes, so this patient gets fibrinolysis.
Fibrinolysis. Give me the drug, the dose, and the contraindications.
Tenecteplase. It is a single intravenous bolus, weight adjusted, 30 milligrams for under 60 kilograms, 35 milligrams for 60 to 69 kilograms, 40 milligrams for 70 to 79 kilograms, 45 milligrams for 80 to 89 kilograms, and 50 milligrams for 90 kilograms and above. The Heart Foundation guideline from 2025 notes that for patients aged 70 and over, half the standard dose is recommended to reduce intracranial hemorrhage risk while maintaining efficacy. This patient is 55, so he gets full dose Tenecteplase based on his weight.
He weighs 82 kilograms. What dose?
45 milligrams, single intravenous bolus over 5 seconds.
Absolute contraindications to fibrinolysis. List them.
Prior intracranial hemorrhage, known structural cerebral vascular lesion, ischemic stroke within 3 months, suspected aortic dissection, active bleeding or bleeding diathesis, significant closed head or facial trauma within 3 months, intracranial or intraspinal surgery within 2 months, severe uncontrolled hypertension on presentation, systolic above 180 or diastolic above 110.
Relative contraindications?
Current anticoagulant use, pregnancy, non-compressible vascular puncture, traumatic or prolonged CPR, recent internal bleeding within 2 to 4 weeks, peptic ulcer disease, severe liver disease. The decision to proceed despite a relative contraindication is a clinical judgment weighing the risk of the infarct against the bleeding risk. In StAMPSville, with limited blood products, I would also consider that carefully.
Hold that thought about blood products. We will come back to it. Before you give the Tenecteplase, what else are you giving alongside it?
Dual antiplatelet therapy. Aspirin has already been given. I add clopidogrel, 300 milligrams loading dose orally, followed by 75 milligrams daily, and anticoagulation. The guideline recommends enoxaparin or unfractionated heparin as adjunctive therapy with fibrinolysis. Enoxaparin, 1 milligram per kilogram subcutaneously every 12 hours, or unfractionated heparin, 60 units per kilogram bolus, then 12 units per kilogram per hour infusion, capped at 4,000 units bolus and 1,000 units per hour, in a patient who may need procedures or surgery during retrieval. I prefer unfractionated heparin because it can be reversed quickly.
Good reasoning on heparin choice. After thrombolysis, what are you watching for?
3 things. Reperfusion arrhythmias. The most common is accelerated idioventricular rhythm, which is usually benign and self-limiting, but I could see ventricular tachycardia, ventricular fibrillation, or bradycardia from vagal response in inferior MI. I am monitoring continuously. Second, signs of reperfusion, resolution of chest pain, resolution of ST elevation by more than 50% within 60 to 90 minutes. If ST elevation does not resolve, the thrombolysis may have failed, and I need to arrange urgent transfer for rescue PCI. Third, bleeding, particularly intracranial hemorrhage. Any new neurological symptoms, severe headache, altered consciousness after thrombolysis means stop anticoagulation, get an urgent CT, and contact Retrieval immediately.
But you do not have a CT in StAMPSville.
Correct. That is exactly the problem. If I suspect intracranial hemorrhage post-thrombolysis, I cannot confirm it locally. I stop all anticoagulation and antiplatelet therapy. I control blood pressure aggressively, and I call Retrieval for urgent transfer to the regional center for CT brain. This is one of the worst-case scenarios in rural thrombolysis. It is rare, but the examiner wants to hear that I have thought about it.
What is the risk of intracranial hemorrhage with Tenecteplase?
Approximately 1% in the trial data, higher in patients over 70, which is why the dose is halved in that age group. The risk is also higher with uncontrolled hypertension. This is why I check the blood pressure before giving the drug. If his systolic is above 180, I need to bring it down with intravenous beta blocker or GTN infusion before thrombolysis.
Let me push you on timing. Symptom onset was 40 minutes ago when he arrived. How long has he been in your ED? When does the 30-minute fibrinolysis clock start?
The clock starts at first medical contact. In StAMPSville, that is when he walked through the ED door and was assessed by me. The target is fibrinolysis within 30 minutes of that first contact. The ECG should be within 10 minutes. That leaves 20 minutes for clinical assessment, checking contraindications, preparing the drug, and giving it. This is achievable if the team works in parallel. The nurse is getting IV access and bloods while I do the ECG. The pharmacist or second nurse is drawing up the Tenecteplase once I confirm STEMI.
Leadership. Who is doing what?
I am leading the resuscitation. The senior nurse is managing IV access, drug administration, and documentation. The second nurse is contacting retrieval coordination and preparing the transfer paperwork. The Aboriginal health worker is supporting the family, because this man has family in town and they need to know what is happening. I am making the clinical decisions and communicating with the retrieval service using SPAR, situation, background, assessment, recommendation. I tell them I have a 55-year-old male, inferior STEMI, thrombolized at this time, requesting transfer for pharmacoinvasive angiography within 6 to 24 hours.
Good. You used SPAR, you named the team roles, and you specified the pharmacoinvasive timeline. Now, before we transition to the mimics, you mentioned that the response to GTN should not be used as a diagnostic tool for ACS. Explain why.
The Heart Foundation guideline from 2025 is explicit on this. A response or lack of response to GTN, standard analgesia, or antacids should not be used as a diagnostic criterion for ACS. GTN relaxes smooth muscle throughout the body, not just coronary arteries. Pain from a wasophageal spasm, musculoskeletal causes, and even anxiety can improve with GTN. Conversely, a true ACS may not respond to GTN if the coronary occlusion is complete. Using GTN response to decide whether this is cardiac pain is dangerous and leads to both false reassurance and unnecessary investigation.
Hold on, you mentioned troponin. How are you using high-sensitivity troponin in a rural hospital where formal lab results are couriered? What can you actually do locally tonight?
StAMPSville has a point-of-care troponin assay. The Heart Foundation guidelines from 2025 recommend high-sensitivity cardiac troponin assays because they are diagnostically superior to conventional assays. They allow earlier detection of myocardial injury and faster rule-in or rule-out protocols. The standard 0 and 1 hour or 0 and 2 hour protocols require the high-sensitivity assay. With my point-of-care troponin, I can get a baseline value at presentation and a repeat at 1 or 2 hours. But here is the key. A single troponin at presentation does not rule out ACS if it is normal. In a STEMI, I am treating based on the ECG and treating immediately. I do not wait for troponin in a patient with ST elevation. The troponin is most useful in the patient whose ECG is non-diagnostic, where I am trying to distinguish STEMI from unstable angina or non-cardiac chest pain.
And the sex-specific thresholds?
The guideline specifies sex-specific 99th percentile upper reference limits, for men typically above 35 nanograms per liter, for women typically above 15 nanograms per liter, depending on the assay, using a single threshold underdiagnoses myocardial infarction in women. This matters in rural practice because women more commonly present with atypical symptoms, and their MIs are more likely to be missed. But in our scenario, this patient has a clear STEMI. The troponin confirms what the ECG already shows. I would not delay treatment waiting for the result.
That is a crucial point and one that examiners test repeatedly. Let us move to Deep Dive B.
Deep Dive B. The dangerous mimics. We have a patient with crushing chest pain, and we have treated him as a STEMI, but what if we are wrong? Let us walk through the two diagnoses that can masquerade as ACS and kill the patient if missed: aortic dissection and pulmonary embolism.
Start with aortic dissection. Why is it so dangerous in the rural setting specifically?
Because the diagnosis requires a high index of suspicion, and the definitive investigation is a CT aortogram, which is not available in StAMPSville. The mortality of an acute type A dissection increases by approximately 1 to 2% per hour in the first 24 hours. If I miss it, or if I thrombolysis thinking it is a STEMI, I can cause a catastrophic outcome. Thrombolysis in a patient with aortic dissection can precipitate rupture and death.
So before you gave the Tenecteplase, what in the history or examination would make you stop and reconsider?
I am looking for the features of the aortic dissection detection risk score. 3 categories: predisposing conditions, Marfan syndrome, connective tissue disease, family history of aortic disease, known aortic aneurysm, known aortic valve disease, recent aortic manipulation, pain features, abrupt onset, severe intensity, tearing or ripping quality, radiation to the back, and clinical findings: pulse deficit, systolic blood pressure differential greater than 20 millimeters of mercury between arms, focal neurological deficit, or a new aortic regurgitation murmur.
Our patient described crushing pain radiating to the left arm. That is classic ACS. But what would dissection pain classically sound like?
Dissection pain is typically described as tearing or ripping, often with abrupt onset and maximal intensity at the onset. It may radiate to the back, specifically between the shoulder blades. It can migrate as the dissection extends distally. This is different from the crushing pressure-like pain of ACS, but there is significant overlap. Up to 15% of dissections present with pain that sounds exactly like ACS, and a dissection involving the coronary ostium can actually cause a STEMI pattern on ECG.
So an ECG showing STEMI does not exclude dissection?
No. If the dissection involves the right coronary artery ostium, which is more common than the left, it can produce an inferior STEMI pattern. This is one of the most dangerous traps in emergency medicine, an inferior STEMI in a patient with a tear in the ascending aorta, treated with thrombolysis. The way to avoid this trap is the clinical assessment before you give the drug.
What specifically are you doing at the bedside?
4 things. First, I check blood pressure in both arms. A difference greater than 20 millimeters of mercury is a red flag. Second, I palpate all peripheral pulses and compare left and right. A pulse deficit, particularly a missing or diminished radial or femoral pulse, is significant. Third, I listen for a new diastolic murmur of aortic regurgitation. And fourth, I use bedside ultrasound. I look at the aortic root and ascending aorta for an intimal flap, a pericardial effusion suggesting tamponade, or a dilated aortic root greater than 4 centimeters.
What is the sensitivity of transthoracic echo for dissection?
It misses approximately 30% of dissections, particularly those in the distal ascending aorta and arch. The sensitivity for type A dissections which involve the ascending aorta is better, around 70 to 80% with good windows, but a normal transthoracic echo does not exclude dissection. Transesophageal echo has a negative predictive value of 99%, but that requires sedation and expertise that may not be available in StAMPSville at 3 in the morning.
So your POCUS is helpful if positive, but not definitive if negative. What is your threshold for action?
If I see an intimal flap on POCUS, or if I find a pulse deficit, a significant blood pressure differential, or a new aortic regurgitation murmur, I do not thrombolysis. I manage the patient as a dissection until proven otherwise. That means blood pressure and heart rate control, and urgent retrieval for CT aortogram and surgical assessment.
Blood pressure control in suspected dissection. Give me the targets and the drugs.
The target is systolic blood pressure 100 to 120 millimeters of mercury, and heart rate below 60 beats per minute. The principle is to reduce the force of cardiac contraction and the rate of rise of arterial pressure, which is what propagates the dissection flap. First line agent is an intravenous beta blocker, labetalol, 20 milligrams IV bolus, repeated and then an infusion, or esmolol, a short-acting beta blocker that is ideal for titration. Loading dose 500 micrograms per kilogram over 1 minute, then maintenance infusion of 50 to 200 micrograms per kilogram per minute.
Why beta blocker first and not a vasodilator?
Because if you give a pure vasodilator like sodium nitroprusside or glyceryl trinitrate first, it causes reflex tachycardia. That increases the force and rate of contraction, which increases the stress on the aortic wall and can extend the dissection. The cardinal rule is beta blockade first to control heart rate, then add a vasodilator if the blood pressure is still elevated. If the patient is hypotensive, which suggests tamponade, rupture, or involvement of the aortic valve, I do not give beta blockers or vasodilators at all. I support the blood pressure with fluids and prepare for emergency intervention.
This patient in our scenario had blood pressure of 140/80. Both arms equal. No pulse deficit, no murmur. POCUS showed no flap. You proceeded with thrombolysis. That was reasonable. Now what if, 30 minutes after the thrombolysis, his blood pressure suddenly drops to 70/40, he becomes pale and clammy, and his JVP is visible and elevated? What are you thinking?
Cardiogenic shock from a large inferior infarction with right ventricular involvement is my first thought. Inferior STEMI commonly involves the right ventricle, which is preload dependent. The right ventricle fails, the left ventricle is underfilled, and the cardiac output collapses. The treatment is volume. I give fluid boluses, 250 milliliters of normal saline at a time, reassessing. I avoid nitrates and diuretics, which reduce preload and worsen the situation. If he does not respond to fluids, I start an inotrope, noradrenaline or adrenaline to maintain perfusion pressure, and I arrange urgent retrieval.
The other possibility?
Cardiac rupture with tamponade. Free wall rupture is most common in the first 24 to 72 hours. If I see a pericardial effusion with right ventricular collapse on POCUS, that is tamponade. The treatment is emergent pericardiocentesis, but this is a surgical problem. I am stabilizing for retrieval, and ventricular ventricular septal rupture or papillary muscle rupture causing acute mitral regurgitation are also possible mechanical complications, these all present with sudden hemodynamic deterioration and new murmurs.
Good. You covered the immediate differential for post-MI collapse. Now let us move to pulmonary embolism. How does PE present in a way that mimics ACS?
PE can cause pleuritic chest pain, breathlessness, and syncope. The ECG may show sinus tachycardia, T-wave inversion in the anterior leads, right axis deviation, or right bundle branch block. In a massive PE causing right heart strain, you can see the S1Q3T3 pattern. Troponin can be elevated from right ventricular strain, so a patient with PE can present with chest pain, an abnormal ECG, and a raised troponin. Without clinical context, that looks like ACS.
In StAMPSville, no CT pulmonary angiogram, no D-dimer available after hours in some rural hospitals. How are you making the decision?
Clinical risk stratification with the Wells score. Does the patient have clinical features of DVT? Are they hemodynamically stable? Is PE the most likely diagnosis? What are their risk factors? Recent surgery, immobilization, active cancer, pregnancy, estrogen therapy, previous VTE. If the Wells score is low and I have a D-dimer available, a negative D-dimer excludes PE. If D-dimer is not available, or the Wells score is high, I use POCUS. I look for right ventricular strain, right ventricular dilation, McConnell sign, which is a kinesia of the right ventricular free wall with preservation of the apex, tricuspid regurgitation, and a dilated inferior vena cava. I also do a compression ultrasound of the legs looking for DVT. If I find a DVT in a patient with breathlessness and right heart strain, that is PE until proven otherwise.
And if you suspect PE strongly enough to treat?
Low molecular weight heparin, enoxaparin, 1 mg per kilogram subcutaneously twice daily, or unfractionated heparin if the patient is hemodynamically unstable or may need thrombolysis or surgery. For a massive PE with cardiac arrest or persistent hypotension, systemic thrombolysis with alteplase is indicated, 100 mg over 2 hours. But in StAMPSville, I would discuss this with a retrieval consultant before giving it, because the bleeding risk is significant and I have limited blood products.
Let us do the rural integration segment. A new piece of information arrives. The patient's wife tells you he was diagnosed with a thoracic aortic aneurysm at 4.5 centimeters 2 years ago at the regional hospital and was told it was being monitored. He never followed up. How does this change your thinking?
This is a critical piece of information. A known thoracic aortic aneurysm is a predisposing condition for dissection. I now need to go back and reconsider the diagnosis. Even though the ECG showed an inferior STEMI and I have thrombolized, the possibility that this is a dissection involving the right coronary artery is now significantly higher. I would check the blood pressure differential again, repeat the POCUS looking specifically at the aortic root, and contact the retrieval team with this new information. If there is any sign of dissection, the management changes completely. Blood pressure and heart rate control, not further antiplatelet or anticoagulant therapy, and urgent surgical consultation.
You have already given the Tenecteplase. Is there any way to reverse it?
Tenecteplase has a half-life of approximately 20 minutes after the initial bolus. There is no specific reversal agent. The fibrinolytic effect can be countered with cryoprecipitate or fresh frozen plasma and antifibrinolytics like tranexamic acid, but I have limited blood products in StAMPSville. 4 units of O-negative blood and no cryoprecipitate or fresh frozen plasma on site. This is exactly why I would be extremely careful before thrombolizing any patient with a history suggestive of dissection. If I had known about the aneurysm before giving the Tenecteplase, I would not have thrombolized. I would have managed a suspected dissection.
That is the point of the StAMPSville scenario. The history matters as much as the ECG. Now, examiner lens. What are the common mistakes candidates make in a chest pain station?
First, not doing an ECG early enough. The 10-minute rule is non-negotiable. If you have not said ECG within 10 minutes in your first sentence, you have lost easy marks. Second, giving high-flow oxygen reflexively. The examiner will mark you down if you put a normoxic patient on 15 liters. Third, not articulating the thrombolysis decision logic. Candidates know fibrinolysis decision logic. Candidates know fibrinolysis exists, but they cannot explain the door-to-needle timeline, the contraindications, or the pharmaco-invasive pathway. Fourth, not assessing for dissection before thrombolizing. Checking blood pressure in both arms and listening for a murmur takes 30 seconds and can save a life. Fifth, not calling retrieval early enough. The aircraft is 90 minutes away. You call them when you suspect the diagnosis, not when the patient deteriorates.
And what separates a passing candidate from a strong candidate?
Strong candidates signposts before expanding. They say, I will assess stability first, then confirm the diagnosis, then begin treatment, then plan disposition. Each of those is a signpost. Then they deliver the detail under each heading. They state exact drug, dose, route, and monitoring for every medication. They acknowledge the rural constraints explicitly. No CT, limited blood products, 90-minute retrieval. And they show leadership. They assign roles, use SBAR for handover, and involve the Aboriginal health worker for family support. They also state an explicit follow-up plan. After thrombolysis, pharmaco-invasive angiography within 6 to 24 hours at the regional center, cardiac rehabilitation on return, medication optimization, risk factor modification, smoking cessation.
Active recall. 3 rapid-fire questions. Give me the aspirin dose in suspected ACS.
300 milligrams orally chewed or dissolved, then 75 to 150 milligrams daily.
Tenecteplase dose for a 75-year-old weighing 75 kilograms.
Half dose because age 70 or above. The full dose for 70 to 79 kilograms is 40 milligrams. Half of that is 20 milligrams.
Blood pressure target in suspected aortic dissection.
Systolic 100 to 120 millimeters of mercury, heart rate below 60 beats per minute, beta blocker first, vasodilator second, never the reverse. Follow-up after this episode is as important as the acute management. After pharmaco-invasive angiography at the regional center, assuming successful PCI and stenting, this patient returns to StAMPSville for ongoing care. His medication regimen will include dual antiplatelet therapy, aspirin plus ticagrelor or clopidogrel for 12 months, a high-intensity statin, atorvastatin 80 mg daily, an ACE inhibitor or angiotensin receptor blocker, and a beta blocker, particularly if there is any left ventricular dysfunction. I would arrange a transthoracic echo at the regional center during his admission to assess ejection fraction and wall motion abnormalities. Cardiac rehabilitation is challenging in a remote town. I would enroll him in a home-based program or coordinate telehealth sessions with the regional cardiac rehab team.
And the smoking cessation piece? He has a 30-pack year history.
This is the single most impactful intervention for his long-term outcome. I would have that conversation while he is in hospital, when the motivation is highest. Nicotine replacement therapy, a combination of patch and short-acting gum or lozenge. Varenicline is first line for smoking cessation in this context, started 1 to 2 weeks before the quit date. And I would book follow-up with the Aboriginal health worker for ongoing support, because relapse rates are high without structured follow-up. This is rural primary care at its best. The acute intervention is thrombolysis. The chronic intervention is risk factor modification. Both are my responsibility as the rural generalist.
Final recap for today.
Today we built the framework for managing acute chest pain in a rural center without PCI. The key priorities: ECG within 10 minutes. Aspirin 300 mg immediately. GTN for ongoing pain, with contraindications checked. Oxygen only if hypoxaemic. For STEMI, the decision between PCI within 120 minutes and fibrinolysis within 30 minutes. Tenecteplase, weight adjusted, half dose over 70. Always exclude dissection before thrombolizing. Blood pressure in both arms, pulse check, listen for a murmur, bedside ultrasound of the aortic root. And call Retrieval early with SBAR because the aircraft is 90 minutes away.
91 days to go. Tomorrow we shift to pediatrics. A toddler with fever and a non-blanching rash. The STAMPS scenarios that test your ability to recognize and respond to sepsis in a child when the nearest pediatrician is 300 kilometers away. See you tomorrow.